Hello everyone, this is Samira Chandra. I'm a resident from Baptist Health UAM's Internal Medicine Residency Program in North Little Rock, Arkansas. Here, I'm presenting a case of refractory severe hyponatremia, not amendable to 3% sodium chloride infusion, eventually was found to be a case of pituitary apoplexy. Few points about hyponatremia. It is the most common electrolyte abnormality and is due to relative water excess in relation to sodium. Where SIADH is the most common cause of inpatient euvolemic hyponatremia, pituitary apoplexy is a rare one. Our patient was a 24-year-old gentleman without pre-existing comorbidities, presented with new onset headache. Patient was found to have elevated blood pressure with concomitant moderate hypoosmolar hyponatremia, mild hypokalemia, and hypochloremia. Workup for hyponatremia was abnormal for low TSH while free T4 level was still pending. Presumptive diagnosis of SIADH was made at admission and patient was placed on fluid restriction. Subsequently, patient's sodium failed to improve with fluid restriction. Patient developed signs symptoms like dizziness, tremor, increased urinary frequency. Patient's lab also were suggestive of central hypothyroidism and renal tubular acidosis. MRI of the brain showed cystic lesion in the pituitary fossa suspicious for Rathke's cleft cyst. Neurosurgery recommended medical management, while nephrology recommended 3% hypertonic infusion intermittently with tolvaptan trial. Patient failed to improve with aforementioned therapy and serum sodium reached to nadir of 114 when patient was transferred to the ICU. Pituitary panel was sent and per endocrine recommendation, patient was empirically started on stress dose steroid and thyroxine replacement for suspected pituitary apoplexy. Outcome in the next few days was amazing and rewarding. Patient's signs symptom improved, serum sodium improved to normal, and other lab abnormalities also got corrected. Pituitary panel came back abnormal for panhypopituitarism. Eventually, patient was discharged to home on replacement steroid and thyroxine. Follow-up MRI later on showed shrinking size of the pituitary cystic mass. Pituitary panel also normalized except the growth hormone, and patient was tapered off from hormone replacement. Coming back to the diagnostic criteria for SIADH, Barter and Schwartz criteria particularly says that kidney function, thyroid function, and adrenal function has to be normal to diagnose someone as SIADH. So per se, our patient never was a case of SIADH. We did several literature review, and I would like to highlight few points from my reviews. There are case reports on Rathke's cleft cyst induced SIADH, diabetes insipidus, and central hypothyroidism. Also, I found that glucocorticoid suppresses ADH gene expression in the hypothalamus. Thereby, in cortisol deficiency, ADH release gets unopposed and thus SIADH-like picture dominates, results in antidiuresis and dilutional hyponatremia. Also, non-anion-gap metabolic acidosis in hypocortisolism associated with the pituitary apoplexy is likely from ammonogenesis impairment in the proximal convoluted tubule. Finally, myopathy can also be explained in hypocortisolism associated with pituitary apoplexy is likely from maladaptive cellular response and concomitant electrolyte disturbances. Finally, the take-home message is that treatment for SIADH is volume restriction, whereas for pituitary failure, it is volume resuscitation and hormone replacement. When we find a case of hypocortisolism, approach should be treatment first in the setting of acute issue, whereas ACTH stimulation test can be done in chronic setting. Thank you so much.